some slightly better than random thoughts about engaging patients. Mistakes we've made that you should avoid, and some dumb luck you may wish to incur. So, we're trying at the beginning to dispel any notion of expertise. And I want to say a couple things. We really appreciated having your data from the surveys. We really appreciated knowing more about you. And learned from that basically there was no way we were going to make everyone in this room happy, not even close. Because some of you want incredible detail and how to measure and, all the way on the left or right or whichever end of the spectrum that would be. And others of you want to say, hold on, time out, start at the very beginning, let's, have some kind of group work to get over the barriers between patients and others and everything in between. So what we decided to settle on was 30 minutes. We're going to limit ourselves in presentation to 30 minutes and then throw it open to you. So we're going to go super fast. So if we get on something that you think, hey, I want to know more about that, you'll know how to reach us. And you can reach us to know more about that. So, and the second thing I want to say is that I've spent all morning going like this, la, 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 because I live in the United States and I choose to entertain the notion that Canada is perfect. That Canada's healthcare system is perfect, that your engagement of patients is perfect, that everything is perfect. So I'm not hearing anything else, I just want you to know. And here we go. I also want to thank you, Canada, because I use this graphic probably more than any other individual slide in my slide set. This is really helpful to solve one of the two problems in talking about patient engagement, right? So the first problem in talking about patient engagement is not really a problem, but it's important from a linguistic point of view to understand whether you're talking about engaging patients in their own care or whether you're talking about engaging patients in policy and education of health professionals and that kind of thing, sort of on the continuum. In the United States, the patient engagement movement sort of roughly kind of grew out of patients getting engaged in their own care, saying, holy smoke, medical errors in the United States, we crash a jumbo jet every day. The equivalent of crashing a jumbo jet every day. 250,000 people in the United States a year are killed by medical error, to say nothing of the number of people who are injured by medical error. So, patients sort of had to kind of get moving and get busy and figure out how we were going to sort of defend ourselves in our own healthcare system. That's how we grew. And then up from that came our interest in, well, we're going to have to change policies, we're going to have to change organizational systems and processes, we're going to have to change how clinicians are trained, we're going to have to change. It went up like that. In the UK, on the other hand, they got very interested in the policy level. The NHS, how this is going to work, citizens, carers, that kind of thing. And it's trying, I think, to trickle down into the clinical encounter, but not so effectively in the UK. There's still a lot of deference in the UK, I think, and a hesitancy to engage in one's own care. So it's just interesting, I think, to think about sort of what are we talking about? Are we talking about engaging in your own care, or are we talking about changing the system, right? And then this slide really helps you think about, people say, what do you mean by engaged patients? We already engage patients. Why, sure enough, we give them brochures, right? And after I got over being horribly offended by that, I said, great, so you inform and educate them. And that's excellent, that's level one. And for some things, level one might be just fine, right? But as you go up the ladder in the continuum, you become a more robust kind of partner, right? And in the last one, level 5, which is called partner, in fact, you're talking about all the same size bubbles. You see that? I assume most of you have seen this before. But anyway, I want to personally thank everyone in Canada for this slide. It really makes my life easier. So everything starts with a story. And that's me at age 38 with children that were 3 and 6 months old. When out of the blue, I was diagnosed with ovarian cancer. It was operated on by a gynecologist who thought it was probably benign. And 6 months later, because he burst it trying to take it out, it was in my liver. And I was told to go home and think about the quality, not the quantity of my remaining days because I had failed chemotherapy, because I was platinum resistant. Do you know a gal who's platinum resistant? I don't know. And I had to go home and think about the quality of my remaining days. Needless to say, I didn't do that. Went for experimental treatment. Here I am, Bob's your uncle. But when I got back to work, I was teaching in a law school, teaching students to do legal work by working with prison inmates. And my job was the same. It was a great job, but I was completely different and kept having these like daymares, where I'm floating over my own funeral with everybody talking about what a tribute it was to my love for my children or my hard-headedness or my whatever that it took so long for me to die, right? When, as it turns out, I could have lived. And I'm screaming, I could have lived! And nobody can hear me. So eventually my oncologist called me and said, I've got this lady, she's kind of down, would you ever come talk to her? I went and talked to her. As I was leaving the hospital after a lovely 2-hour late afternoon conversation about dying and how do you talk to your children and this and that, I was leaving and she picked up an envelope off of her bedside table and said, hey, you're a lawyer. My doctor wants me to be here for 5 nights, but my insurance company is only willing to pay for 3. Can you help? And I said, give me that. And by early the next morning, the insurance company had seen the wisdom of a 5-day stay, and I was completely addicted. I was like, I need to do more of this. So I entered what I call my knight in shining armor phase of advocacy, doing for people. Well, it took me about 6 months to figure out that there were way more people than we were going to be able to do for. And I also realized that I didn't necessarily want to train a new army of people called patient advocates because in the US, they would never be paid for. The insurance companies aren't going to pay for patient advocates who actually work for patients. They pay for patient advocates who work for insurers. And so I sort of started thinking, saying, wait a second, patient advocates, that should be doctors and nurses and lawyers and pharmacists and genetic counselors, and all clinicians should be patient advocates. This should be part of their training. So that's kind of how we got started at the Center for Patient Partnerships. The core of what we do, you'll see in a minute, and the sort of the beginning of what we do was an advocacy center for people with life-threatening and serious chronic illnesses. People call us from all over the country, all over the world, and they say, help, I've been diagnosed with this, I don't know what to do with it, and we put an interdisciplinary team of students on it. So med students, law students, nursing students, pharmacy students, counseling, psych, industrial engineering, any graduate level student with an interest in the future of healthcare comes there and does 1 or 2 semesters of direct service advocacy for people who are diagnosed with something they can't pronounce, they don't understand it, they don't know what to do about it. Or they know what they want to do, but this is my second reoccurrence of breast cancer. And I know which clinical trial I want to get to, but my insurance company says it's not medically necessary or it's experimental. So we help with insurance and other kind of barriers. And the third major thing is employment, because in the United States, healthcare is linked to employment. If you get sick and lose your job, you lose your insurance. And when we started, there was no bar for pre-existing conditions. There was no Obamacare. So we help people maintain relationships with their employers so that they don't lose their jobs, and so that employers don't say the nice things they say in the beginning, like get whatever you need, and then about 92 days into chemotherapy, they're like, when are you coming back? We can't hold your job forever, which makes this is discouraging and dispiriting for everyone. So that's basically the core. That's what we started with. If the 20th is one of my favorite. Former dean of the School of Engineering, the 20th century was about thinking the world apart, about splitting the atom, about being able to look at things as in their actual components, right? Pulling them apart and examining them and learning more and more microscopic things about the world. But we've lost something, right? We've created silos in so doing. We've lost a wholeness, a connectivity that, at least in our minds, was the halcyon truth in the old days. And so if the 20th century was about thinking the world apart, then the 21st century needs to be about thinking it back together again. And the question I think you may have in front of you is, what unique role can IHPME play in thinking healthcare back together again in your country? And for that matter, to help us all figure that out in the rest of the world. So think of that as a potential kind of overarching question for your effort. Whoops, I need to go backwards. We are a center of the University of Wisconsin. We're a center of the School of Medicine and Public Health, Law, Nursing, and Pharmacy. So we were the first truly interdisciplinary center on campus, by which I mean every faculty from each department voted yes, and then the Central University Committee voted yes, and started in 2000, basically. So we've been at it 18 years. Oh, God darn it. Be patient. It's not my strong suit. So this is the sort of graphic for those of you who are visual. This is kind of what we do. We infuse patients' voices in the sort of whole process of healthcare, right? So there's the tea bag with patients' voices, with a little tab, right, that's taking it over to the teapot. We do that through advocacy, through professional education, through service co-design or organizational system redesign efforts, and through research and policy advocacy. So we're going to tell you a little bit about those 4 areas. Well, actually, I just told you about the first one, and now you're not going to get much more about it. And we're going to tell you a little bit about so education, organization and system reform, right? And research and policy advocacy and reform. So that's where we're going. And the goal is better health outcomes. So this is a sort of our, what do they call this? What is this called? This is like called something like your intellectual, I forget what it's called, your model. Conceptual model or something like that. I don't know. Anyway, so we take patients' experiences. Oh, well, first we take students into education, right? And we bring patients into the mix and have them do advocacy with patients, building capacity in patients themselves, right? It's a little tricky, of course, because what you're actually doing is trying to teach a student who's never done a thing to partner with a patient to do the thing they've never done. Yeah, it's an uphill climb, I'll give you that. But it certainly helps. It helps if we think of it all the time as we're a community of learners, all of us. The faculty, the students, and the patients are all part of one big community of learners. Then we're just kind of all learning together all the time anyway. We add patients' experiences, and we get interested in those patients' experiences. And we say, hey, we've seen a bunch of these, So then we research them. Hey, why did this happen? What's going on here? What's that? We identify issues for system change and research those concepts, right, those possibilities for system change, and then we effectuate system change. And then that changes education, and it sort of goes around like that. That's the general idea. We work at the micro level, engaging patients in their own care. At the meso level, engaging patients in co-designing systems and healthcare services. And at the macro level, reforming policy, engaging patients in reforming policy and shifting paradigms. Our overarching goal, remember we're an educational institution. We're not a freestanding patient advocacy center, we're an education center. Our overarching goal is to educate a new generation of professionals, to teach students to partner with patients, to transform healthcare across the board, from the clinic, from the clinic rooms to the halls of Congress, and everywhere in between, right? We don't want to just, it became clear to us very early on that it was going to be important to us not just to jump up and say, yeah, we're about patients' voices. Really, we are. Look, I'm a patient and here's my voice. That we really needed to develop the science of collecting patients' voices. Because this was not going to sell in any boardroom or in any decision maker's office unless it had, what someone articulated so eloquently before, data, right? Information. So the science of patients' voices is very important to us, and Rachel's going to talk more about that. So here's our theory of change. Students and faculty and patients, so you'll notice they're white and red for those of you who are visual that way. Through professional education, research, and sharing our expertise, we affect professional practice, issue advocacy, and sit on sort of national boards. All that results in organizational reform, state and national policy change, and ultimately system change. So that's kind of how it's supposed to work. Supposed to work. It doesn't always work that well, We publish what we learn. So we've published about engaging patients in primary care redesign, about implementation science and practice redesign, about the state of the marketplace, consumer assistance navigators. We've talked about, anyway, we try to publish what we do partly to normalize and kind of raise up the profile of engaging patients and the science and practice of engaging patients. Because one of the complaints frequently from academics will be, hey, I'd love to do this, but it's going to sink my tenure because it's not scientific enough, or it's not this enough, or it's not right. And some nodding heads in the room. Well, if we want this not to sink your tenure, we need to raise the specter of it, to make it legitimate, and patients can help with that, right? We can be some of your best collaborators in that. So we share our expertise. We work with all of these organizations and a lot more to bring to sort of incorporate their expertise in our work and to bring some of our experience and knowledge into theirs. We serve on the boards of health services organizations, of the National Quality Forum, which is, probably you know, this is a major kind of measurement organization in the United States, the National Cancer Research Advocates at the National Cancer Institute, to advise the director of the institute on research priorities in cancer. American Academy, anyway, you see Stephen. Oh yeah, your turn, Rach. Take it away, Rach. I'll be back.
So I realize I should have written a bio that said, I am someone who will go wherever Meg Gaines invites me. But you didn't know her quite well enough to get that yet, so I figured I'd do my own introduction. I met Meg about 13 years ago, and then came over to the Center for Patient Partnerships about 7 years ago to direct the national initiatives and really deepen our system change, policy, and research side. Because although I'm a caregiver for my mother and a patient like all of us, I don't have the personal story that Meg does. I sort of bring these other kinds of skills, so many of you in the room who are really passionate about this work may relate to the kind of way Meg found herself coming to it, and others may relate to the way I've come. It's a great gift to be at CPP. And what I'm going to do now is very quickly, so forgive me for running through quickly, share some more specific examples. As Meg said, we know we can't make you all happy, but we are charged with some of the what. So we decided we'd do a couple of concrete examples in a little more depth of the kind of patient engagement and patient-engaged policy and research work we do, throw out a couple of others that you could ask us about during the Q&A, and hope that that would be useful to you. So here's another patient engagement framework. This one's from the US, and it lays out this sort of direct care, organizational change, and policy-making change. And with our national initiatives, we're filling in some gaps, including moving from voice to voices through qualitative, engaged, applied, and policy-relevant research that helps us understand what's happening to people outside of our clinic around specific issues. And I'm going to give you an example in a minute. And then also working to help people who are representing patients to understand that broader experience base. So we're going to give a few examples. The platform on which we have built a patient experience ambassador model and a medical education model that I'm going to review with you now is a patient experience research platform that is international. It actually derives from Oxford University in the UK, and there's a DIPEX, as it's called, Database of Individual Patient Experience project in Canada that Susan's involved with. I know Carrie's been in the UK working with that group, and We are a big part of leading a health experiences research network in the US. And what is special about this is that the idea of engaging patients in telling their own stories and then in being builders and custodians of what happens with those stories is to help other people and create a publicly available resource where a rigorously elicited, systematically designed overview of patients' experiences with whatever. I'm going to give you an example of depression, but it could be cancer, it could be having a child with medical needs at home, it could be palliative care, it could be anything. In the UK, they've done literally 100 of these. That the idea is that it's not going to be just for publication, that dissemination and implementation is built in. So people are engaged for action. It's also a way of engaging people by going with your video camera to people's homes, those quieter voices, the people who aren't storming the halls of the legislature, who aren't talking to the media, who aren't activated, who aren't extroverts, are able to be engaged by telling their story and knowing that it's going to be of use to other people. So the range of engagement activities that inform and shape and are essential to this process include advising the scoping of studies, health experiences work that we're going to do, what should we study, how should we study it, being the people who are there's a researcher and a person telling their story. Those interviews are qualitative, they're co-created. We have an advisory board structure, we have a lot of involvement in dissemination and implementation, and then we have a national steering committee for this work, which is happening in lots of other institutions besides at the University of Wisconsin. I'm going to give you some examples from our module on experiences young adults in the US have with depression. And here's just a view of how this looks. The interviews, which form the basis of this health experiences research, are done in people's homes and community settings. And then instead of me writing a summary of what I heard, there's video clips, so people's faces, if they so choose, or their voices if they want audio only, around there. And you can see here a little screenshot of how this looks. We did 40 interviews. We used maximum variation sampling to try to get the broadest possible set of experiences so we really understand what is happening for people, in this case around depression experiences. And then this public-facing resource is on the web. It's got about 300 analyzed video clips that illustrate both the theme and variation in the data. So that's the basis, the research basis on which we have built a engagement strategy called Patient Experience Ambassadors. And those ambassadors were people who told their stories in these interviews. Some of them then sat on the advisory board, and many of them then became a cadre of ambassadors to do implementation science, to do dissemination of the work, to make sure that these stories were being heard, to talk to the media, to do social media advocacy, to take it and do presentations in their high schools and colleges, to write op-eds, to talk to their friends and family about it, to help us do a more formal evaluation. So they worked on dissemination with us in many ways. You can see there a description of what an ambassador are. The job description, as we wrote it, and Mike's going to talk a little bit more about job descriptions in a minute, was to thoughtfully represent these experiences. The idea, again, is to be the custodian not only of your own story that you've told, but of these maximally various stories as a collective. So your expertise as a representative is attached to a specific constituency and to the rigorous collection of narratives. I talked about some of the promotion activities already. The sharing of community resources was essential. Here are some skills, that learning that Meg mentioned, the sort of being in a learning community. Everybody in this project did a lot of learning from each other. There's a lot of vulnerability on all sides and a lot of experimentation, which I think is essential as a prerequisite to any meaningful engagement activity. It was a big success in that way. And here's a couple of things we did. We had our patient experience ambassadors and staff for our health experiences network go together into a variety of conference and other public settings. You can see a couple snapshots there. We had people do social media dissemination on Reddit and on Facebook and on Twitter. And one of our patient experience ambassadors was interviewed for a television segment, and the website and the tool resource was kind of marketed and discussed in this segment, but our ambassador also went live and agreed to be filmed and was on TV, and this has been widely used by people across our network. We also developed a toolkit, which really will be up any day now on our health improvement program's website at the University of Wisconsin, so stay tuned, and if you're interested, maybe Susan and Carrie can interview the link when it goes live. So anybody who might be interested in learning more about this model or trying to do it, we distilled what we learned, what went well, what didn't, the questions that we still had in a toolkit format.
I think I edited that.
We did a control experiment design. We did an online curriculum I'm going to give you a quick snapshot of. We did a 1-hour in-person meeting with them to talk about their reflections. And our target was to bring patients' collective voices into the classroom for third-year medical students in primary care rotation, this was, and to see what the impact would be on stigma and empathy and on how broad their understanding of experiences with depression was, rather than the sort of narrow segment of who they might have seen in clinic on their rotation. So there you go. I talked ahead of the slides, and you know that already. Our online curriculum took pieces of the public-facing resource we made, the website, based on the research study, and so we exposed folks to what the interviewees said about signs and symptoms of depression, its relation to anxiety, what it meant to go public, how did people disclose their depression, what did that mean to them. We wanted to get at some things that don't necessarily come up easily in the clinic visit, so we exposed people to what people said about the impact of pets on their lives, on their depression. It's amazing. It's really fascinating how important pets are to depressed young adults, and that we hadn't even asked about that. That really came from when we started talking to people, them telling us that, and then we started asking about it. And then things like everyday life. How do people manage doing their laundry, getting up in the morning, getting to class if they're a student, their work lives, and so on. Our education model is always really based on reflection. We use that as a pedagogical tool, probably to excess, but it works for us. And so the curriculum, the online curriculum, had 5 reflections. We asked people to reflect on what they knew already, and of course this module was about young adults, and many of the medical students were in that 18 to 29 age range, so we had a lot of reflections of people of their own experiences or people that they know. We always ask people to reflect on what surprised them, because people think they know a lot already, so looking for that outlier, what surprised or struck you. On the website, not only are there topics like depression and pets or everyday life, the ones I just showed you, but there are full bios and then all the clips from each interviewee's interview, so you can really get in there and say, well, what did Rachel Grob say, and get to know me. So we had them get to know some individual people, as well as looking at the summaries, the topic summaries of the aggregated qualitative testimony. And we in the process of getting them to spend a lot of time with one person, had the opportunity to get them to do some listening where they didn't have to respond. They're not on the spot to act empathically, and then to reflect on kind of where they got stuck, where they got distracted, where they got judgmental. And I think that this probably had the biggest impact of all. We asked them to look at the stigma data and what they noticed about the range of experiences, so not just something modal, but the outliers as well, again, to do that move from voice to voices, and then on sort of living with depression. So here is a strategy for taking a deeply patient-engaged enterprise and bringing it and the exposure into the educational setting. I'm not going to really say much about the study design because I want to leave a lot of time for questions, but anybody who's interested, and some of you were, in measurement can ask us more about that. Here are just a couple of quotes from students about the power of listening to the videos. One said, "Listening to these videos helped me understand what it would feel like to suffer this way. I feel more empathetic toward those suffering from depression now. And I know that no one would choose to feel that way." So again, kind of getting at the judgment that can often underlie and undercut that kind of openness that we talked about this morning to challenging dialogues and different perspectives. So I'm just going to finish up for a minute with a couple of teasers for other things that are the what of what we do at our center. One is that we have developed, again, relying on qualitative methodologies, open-ended questions to accompany our National Patient Experience Survey, which is a survey design with close-ended questions only, and our National Agency for Healthcare Quality and Research has now adopted this as a supplemental item set, and reimbursement is based partly on these patient experience survey scores. So we really feel like at the system change level, this ability to engage people in giving their feedback by saying, please tell us in your own words about your experience, but also bringing rigor to the design of those questions so that we get the most rich and actionable data possible. And then now we're working on a pilot with New York Presbyterian Hospital, and we've got federal funding to pilot the use of these narratives for quality improvement in outpatient clinics, and we've got other folks around the country interested in this. The narrative questions are being used consistently in Massachusetts. They've been piloted in California, so we're starting to see some impact around patient voice and engagement there. We've got a project going looking at the role of patients and families in learning health systems and understanding how patient and family advisory committees engage in learning processes around the United States. And we've got seats on a couple of Institute of Medicine committees, one on affordable prescription drugs, which is kind of an oxymoron in the United States, and the other on sort of vital directions for the future of the healthcare system, particularly as a transition in political power was happening in the U.S. So I'm going to leave it there and turn it back over to Meg.
So I want to take you quickly through things to remember when engaging patients, and I can talk much more about any one of these that you want more detail about, but we want to get to you quickly. The first one is careful preparation is critical. Organizations should know when, how, and why they are engaging patients. That's what you're doing here. And adapt patients' skills, education, and training to the allocation of their roles, just in the same way that other members' attributes are considered and skills are considered when selecting them for committees. So, figure out who it is you want and make sure you get patients with that skill set, not just, we need a patient. Second one, organizational culture is a significant determinant of success. When leaders understand the value of engaging patients, that's why I kept asking this morning, why are you doing it, right? to the organization's mission, when they are committed, enthusiastic, and realistic about the time, effort, and resources required, success is much more likely, right? So you need leaders that really get it, really buy in, and are willing to prioritize it, and you need people on the ground to do the work who have a great deal of passion for it. Those are both super important. And also, organizational culture has to change. When you invite new people into a process, you don't just say, there's a chair over there. When you invite someone over to your house for dinner, you don't just say, come on in, there's a beer in the fridge, make yourself at home, right? You prepare, and you change how you do things, and you think about whether they eat meat or not, and you spend some time, and it's actually often a real opportunity for the organization to look at culture again. And to say, hey, this isn't working for any of us, much less will it work when patients get here. Communication is vital. I'm not going to say more about that, except that I think for patients understanding why they're here, what their job is, and what as Francine talked so eloquently this morning, what's in it for me, what's in it for you, and why are we here? That's the only way you're going to be able to make sure that in a moment where you think a patient, or for that matter, a clinician member of a committee is kind of off the rails, is kind of not on the topic that we're here for, that's the only way you have permission to jump in and say, that's really important, but that's not actually what we're talking about right now, right? So you need to sort of get that defined so you can monitor it. Job descriptions fit the patient to the job and make sure that the description is clear. And in fact, the job description for everybody is a good idea, for everyone at the table. I already said it affords organizations an opportunity to re-examine culture. Who's on your committees? How do you run them? How do you make sure everybody gets a chance to speak? Has anybody here ever been in academia and been really annoyed by the fact that one person talks over and over and over again? Ever had that happen? Imagine what an opportunity this is to create real processes so it doesn't happen for anybody in the room, right? So it's as a leader, it's a great excuse to say, we need to look at this because these patients are coming in and we're not sure what they're going to do. So it's a really cool opportunity, excuse to revamp it for a lot of reasons. It's really important to approach this as a community of learners where awkwardness, inadvertent miscues, and other aspects of engaging patients in a new way are understood as expected, well-intended, and an opportunity to understand it better, right? On everyone's part, which is why you got to choose both the patients and the other folks carefully, and train them carefully, and job descriptions carefully. This is particularly important where the new partners are not actually new to one another, right? The new partners but they're new partners in the work of this organization. So you're inviting my patient, if I'm a clinician, into the room, and I'm now supposed to have a different kind of relationship with that person, right? The patient's not always right when you're in this room, right? The patient doesn't always have to be deferred to when you're in this room, and maybe does more have to be deferred to in the clinical setting, or at least that's the history. Really important for organization to understand that engaging patients begins slowly, and that the opportunities and desire to engage patients will grow over time. It's one of these tensions you have to preserve. You got to do it fast enough to keep people interested, fast enough to keep the passionate people on the ground feeling fed by this engagement effort and where it's going, but slow enough to make sure you're not driving past things and people you need to pay attention to. Engaging patients, professional patient advocates will generate an educated and less diverse group of patient partners, right? It's important to examine every activity that you do, and someone mentioned it earlier about the different ways to engage patients. Not everyone has to be on the board, right? Not everyone has to sit on a committee. Where you are engaging people on a committee, but you know you want to reach people who it doesn't make sense for them to serve on a committee, for you or them. You want to have ability to appear virtually. You want to have virtual focus groups. You want to send out qualitative. You guys know about mixed methods, so you know about this, but it applies both in research methodology and in engaging patients, that the kind of The variety in methodology for engagement you use will affect what you get. Engaging patients is resource intensive. You really do have to invest in it. It's a terrible thing to do without a lot of money. And don't do it because you think it's a justice activity. Do it because you think it makes the work better. A justice activity is not likely to sustain people for very long, particularly scholars. They have careers, they have promotions, they have tenure, right? They need to feel like they're actually improving the work. So do it because it's not because it's the right thing to do morally, but because it actually leads to better outcomes in research, in education, in clinical settings. Methods matter. Do you want me to do that one, or do you want to do that one? Methods matter. So the methods you choose will affect the outcomes you get. Yeah, you better do that one. I'm losing my mind. There's no such thing as the patient voice. I think Rachel already talked about that. We want to go from, we've gone, as I say, in the course of 20 years of the center, we've gone from no voice to the patient voice, to now we're sort of pushing it on to patients' voices, right? The diversity and richness of voices. And then this is written about quite a bit in the literature, but you have this is a tension you'll preserve over time about as patients become experts, as they become less and less able to, if they ever were in the first place, represent the patients' voices. And as they become basically identified very much with you and what you do in the organization entity, and they become, in essence, in some level, co-opted by the effort they're doing, you just need to keep remembering this so that the diversity of your patients, the ones that are experienced, that you work with a lot, is balanced by people who are not experienced and you don't work with a lot and represent a different kind of input. So those are the pieces we. And then we want to know what keeps you up at night. And we want your questions and concerns and like that. So, talk to us.